Welcome to Chelsea's Vocation. Chelsea raised two children on the autism spectrum, Justice and Noe, into adulthood. They're the reason why she can't help but smile when she recognizes autism in another human, especially a child. Chelsea spent almost 2 decades studying this neurotype as a parent professional, learning how to better adapt her own behavior and the environment around autistic children to both encourage and foster their development. She hopes through this podcast that you might better understand how neurotypical people process your neurology if you're autistic, or how to better yourself as someone who values autistic humans and your relationship with them. Chelsea is a lifelong learner and expects you are too, so don't hesitate to reach out to her through social media comments or the contact form on our website with your own insights. If you're coming to this podcast after the first 5 episodes, you may want to go to the show and review one or more of those foundational episodes to know where she's coming from. Either way, we're glad you're here now.
Not that I want you to pause this podcast and go back to one of the first few episodes of this show, but if you haven't listened to episodes 1, the intro, 2, Justice's story, 4, my story, or 5, my husband Pete's story, you might really want to after this one. Here's why. Before my firstborn was diagnosed with an autism spectrum disorder, there were lots of terms thrown around, some of which were clinical and some more practical. There was global developmental delay, and then pervasive developmental disorder. 3 people said autism out loud to me in the span of a few months. Going through the process of a neuropsychological evaluation with Justice was life-changing for me and my husband first, and our son next. It put us as parents in the right frame of mind to understand the constellation of symptoms that we'd observed for the first 4 years of Justice's life and make some sense of them. Receiving Justice's diagnosis didn't change who he was, but it changed how we interacted with him and did our best to understand what his behavior was telling us about his lived experience. When my now in their mid-20s children, Justice and Noe, were being evaluated for autism and other aspects of neurospiciness, it was under the authority of the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, 4th edition. The DSM-4 was published in 1994, had the umbrella term pervasive developmental disorder, which included Justice's diagnosis of pervasive developmental disorder not otherwise specified, or PDD-NOS, and Noe's diagnosis of Asperger's disorder, also known as Asperger's syndrome, among others. In the DSM-5, published in 2013, the APA did away with those diagnostic subtypes and combined them all into autism spectrum disorder, with levels 1 through 3 indicating increasing support needs. For an ASD diagnosis, children, because that's the presumptive life stage of screening and diagnosis, must present with persistent deficits in social communication and interaction, plus have restrictive, repetitive behaviors, interests, or activities at an early age. It gives me great pleasure to introduce to you Dr. Amy Heffelfinger, who diagnosed both of my children and followed them into their teenage years. And we're also joined by her colleague, Dr. Lauren Miller. I encourage you listeners to check out their bios in the episode description because they are absolute powerhouses, and I am really fortunate to have them on the podcast today. Welcome, doctors.
Thank you. It's great to be here.
Very exciting.
All right, so the DSM-5 criteria for ASD have been in play for more than a decade now. While it seems to me that covering a number of former diagnostic labels under one autism spectrum name has simplified things, I have not been crazy about the levels. How have you seen this change play out in clinical and practical applications, doctors?
First of all, I will acknowledge that I was trained exclusively under DSM-5. So I never had to diagnose anyone according to DSM-4. That said, I'm with you. And I often tell families that when I'm giving a diagnosis, I do always give a level of support, but I am very honest with families that I don't love them either. I think they're a little bit limiting. I think they're fairly misunderstood about what they mean. And so what I often tell families is that they loosely correspond to mild, moderate, severe, but that's not necessarily exactly what they mean. I do like the terminology of level of support. I think it's friendly and more accessible language. But I think the biggest thing that I always like to emphasize to my families is that they're flexible categories, that a child can move through the different levels of support. And in some ways, one of the goals of intervention is to ideally shift a child's trajectory more towards a level 1 classification. But sometimes what happens is that the slide goes the other way. And I definitely have examples of children that I've seen where once you hit a different social transition point, your support needs can actually increase rather than decrease. And so I think it's really important for families to understand that they're not static categories. So I do agree with you, not the most perfect.
I think the reason they would make me so salty is that everyone needs varying levels of support depending on their stressors, right? So on a day-to-day basis, I don't require a whole lot of support. But if I get in a car accident, I'm going to need a whole lot of support because I'm going to be an emotional wreck and I probably won't have good social skills. So I think, okay, what level of stress are they under when they're coming in for this evaluation? And to your point, Dr. Miller, when their brain is being bathed in hormones during puberty, they're probably going to need some more support.
Absolutely. And for me, I predominantly see children in early childhood. A lot of the kids that I see are 2 and 3 years old, and a toddler's level of support is undeniably going to be higher than a child who's 8, 9, 10 years old for most cases, just because they're young and they need parental guidance. They need support. They need teachers to support them. And then if we add additional neurodevelopmental differences, so for example, you mentioned global developmental delay. If we add that on top, or we add ADHD, or we add a language delay, all of those factor into support needs as well. I think it's really important for families to understand that and not place too much weight on them. The reason I still use them, though, is because I've heard from families that for some intervention providers, they really want that full diagnostic label. And I've had families come back to me and say, hey, you didn't include this on your report, and I'm really being told that I need it. Well, we don't want to create even more barriers to families accessing the intervention services that they want to choose. And so I go with the system. I try to stick with DSM-5 as much as I can, despite my personal reservations.
Dr. Amy, do you have anything that you want to throw in there about that?
No, because I did not train under the DSM-5. I have to remember for that reason that Dr. Miller said to include the levels because it helps the families and to use the definitions to follow those diagnostics, but then also to say when we're talking about what we're looking at for your child's future, those levels don't tell you what you think they're telling you by us giving them. And that is always the hard part.
The neurodiversity paradigm kind of says that a different neurotype like autism is just part of the extension of human existence. It's not necessarily a disability. So has the neurodiversity paradigm shifted how you perceive neurodevelopmental pathology?
I can start with that one. I think that's a good one after 25 years practicing here at Children's in Medical College of Wisconsin. I think that it's made me more aware of the way that I communicate with families and communicate about kids, because the reason that I would use a term for disability is really to say this individual needs additional supports and they're probably going to need those additional supports. It's to help the families and to help the child, not to say, oh, there's something damaged and wrong with you, but that in order for you to live your fullest life, we need to help you get additional supports, which sometimes actually does even mean financial disability support or having that support through a school district or from whatever you're doing. I think I always was careful with the language to not make children and families feel as if there was something wrong with the child that we're working with, but to make sure to say that overtly, to say it's not that there is something inherently wrong with your child because they are on the autism spectrum. But the reason we use the term disability is the same reason we have to say that there's a certain level of need. Otherwise, we can't get help or insurance coverage or support or therapy. And then we're not going to make progress.
Amy, I think everything you just said is really spot on. What I often talk with families about is diagnoses being tools. They're a means to an end, particularly in the society that we live in right now, which is very diagnostic and insurance driven. That's an unfortunate situation, but it is the world that we live in. Amy spoke a little bit to the changing ways that we think about autism and symptoms and intervention over the last 25 years of her practice. And I've definitely seen it over the last 10 plus years of my own. And I think if we're kind of really focusing in on more of the neurodiversity lens, it does influence how we think about or how we interpret certain symptoms related to autism. in particular the behavioral symptoms. So for example, stimming. Back in the day, even when I was first training, the guidance was really, well, we don't want to see stimming, right? We need to, quote unquote, fix that. We need to stop it. We need to redirect it. And that's not really the mindset that we have anymore. The mindset that we have at this point is that's a physiological manifestation of something that's going on with a child's nervous system, with their sensory system. It's maybe a form of communicative behavior. And at this point, we can honor stimming. We can allow stimming to happen unless it becomes harmful to the child or it's so frequent that it's interfering with other things that they need to be able to do. And then we can help them learn how to shape that behavior or tweak it in a way that's still functional for them. But the goal is not to get rid of it. And so I think that's a positive way that the neurodiversity movement has shifted how we might think about certain symptoms of autism.
Yeah, and that's exactly where I was going with things like that. We're moving right along. What do you got, Dr. Amy?
I was going to add one thing. Now that we have so many young adults who have grown up with autism and are talking about it, and it is often a central focus of their lives and their identity, and they will talk about the process of having been diagnosed or having had to go through therapy, particularly ABA therapy. What that's doing now for us as we're diagnosing our young children is that parents who are in the same age group as these people who are opponents of ABA therapy some of the time, coming in and saying, well, I don't want my child to have ABA therapy because these individuals who are adults who have had ABA therapy hated it. And we're like, and they're talking about it. They're communicating to the world about their experience. Like, let's first of all celebrate that win, right? And so we actually have to do a lot of talking with families about how ABA has shifted what is a maybe kinder, gentler, more informed from research approach to ABA, but that is still the essential treatment in order to have someone be able to develop, not always, not for everybody, but to develop in a way that they are able to communicate and have really good communicative social relationships to the best of their innate ability. And so I think I had not been prepared for all of my patients to start talking about this, and I love and respect how they do and what they inform us. And also that we have to tell people like, well, we do want your child to be doing as well as these young adults are doing. And we have to think about that.
I was really impressed last April when I went to the state autism conference, and even the year before, there were some ABA providers who were really talking about child-driven intervention, child-led, child-focused, strengths-based, and that is not the way that ABA was back in the day. ABA, when my kids were going through it, and I didn't really notice it so much in the application and the practice in my home, but where I noticed it was as a parent professional presenting at an ABA conference and sitting in on a couple of the sessions. And some of those presenters really philosophically weren't far off from Ivar Lovaas' taking operant conditioning of an animal and applying it to a human being as if that human being has no control over their destiny or no preferences, no capability to protest. And I was opposed to that. So
yeah, skin crawling as you talk about it. Yeah.
It's awful, right? I think trusting people with autism, even if they're small humans, is really important in this process. Because I'll tell you what, of all the autistic humans I've known, I have not known them to lie. They don't make stuff up. They don't see the point. So it's really important to believe them through all of those interventions, I think.
I think there's really no one size fits all approach, and it's language that I use with my families when I diagnose as well. We have to both honor the families and the children while also really providing families with the best that we can in terms of the current state of the science, which usually involves debunking a few myths, because the unfortunate reality is that there is a ton of information about autism out there right now, and not all of it is good information. And some of it's really scary information, to be quite honest.
So I think, Dr. Miller, in that same vein, and you've touched a little bit on the value of obtaining a diagnosis. What's the point of going through this criteria? What's the point of going through this process? You mentioned that getting a medical diagnosis is a way to access services, whether in the community, say through a Medicaid waiver, or in the school through an IEP that's designated for someone with autism. Are there other advantages to obtaining a medical diagnosis?
I think those are huge ones. Accessing services, accessing interventions, for example, something like ABA therapy, but also other therapies, families receiving financial or disability related services and supports. But I also think there's some benefit in just having an answer. I think so many families come in, and again, I'm primarily seeing toddlers. Toddlers are not so much wondering what's going on for them, but eventually they will. Their parents are wondering though, right? Their parents are really wondering, why does my child do this? And my sister's or my best friend's child do it this way. And so I do think having that peace of mind or clarity is really, really useful for a lot of families. It gives them a framework or a lens through which to understand their child. And for some autistic younger people, adolescents, young adults, understanding that diagnosis can be really useful for their sense of self too. So I think that's an additional benefit of pursuing a diagnosis.
Anything you want to throw in there about that, Dr. Amy?
I think that the understanding just so helps everyone who's involved to understand better and to understand better how to interact. And I think it takes off maternal blame, paternal blame too, but especially maternal blame and that sense of like, I'm just not doing enough. I'm not doing good enough here. If I could be different, then that would work. The amount of relief I see that mothers feel is often just a huge component to it.
And there's where I want to direct people back to the Pete episode of this, Dr. Amy, because my kid's dad, Pete, really, it sounds blasphemous, but had his come to Jesus moment in your office, Dr. Amy. So we have you to thank for that. Yay for medical diagnosis. Woohoo.
That's right. I remember the two of you sitting in our tiny little office and having that very emotional, impactful, loud conversations. Dr. Miller and I have to do the work to set up the relationships with the families so that we can communicate when the parents are ready to hear it. Yeah. Usually moms are on board a little bit before the dads.
Sometimes because sometimes the dads see much of what we're talking about in themselves. That obviously happens for moms too, but I've definitely noticed that. I think it's important for families to recognize that there's obviously no one right way to respond to a diagnosis. I think many times we do experience that parental relief, but sometimes there's a lot of grief, and sometimes there's both of those emotions at the same time. And families have to be ready to receive a diagnosis. And sometimes it's not at that moment in your office. It's 6 months later, it's 2 years later. And so I think it's really important for families to take the time to process what we're saying. Having it said out loud is different. And sometimes it's met with, oh my gosh, we have an answer. Now we can do something about it. Now I understand who my child is. And sometimes it's met with, oh my gosh, this was the last thing I wanted you to actually say because I've been worrying about it for so long.
That is a really important point. Also, anger is one, and that's a hard one for us sometimes because often it's directed at us, but we can take it. And I think that's something that we have to remember is people are also going to be angry that they now have to think through this and deal with this and cope with this. It's not that people are usually joyful in our office. There's a lot of tears, a lot of denial, a lot of frustration.
Well, episode 4 of this podcast was my story, and I went through those 7 stages of grief as defined by Nurse Jenny Wright and applied them to my experience as a parent. And then when I was able to look through my experience in that lens, it helped me to notice what stage other parents were in of that journey. I'm sure that there is some backlash around that. Well, you don't have to grieve an autism diagnosis. And you're right, you don't, but I did. And I found a lot of other families do. And I might not have recognized that as a grief in every stage that I was going through, but it helped me to kind of create a rationale for what I was feeling and help to move through. Even if I found myself re-traumatized by something that happened in the community, a new diagnosis with my kids. For a while there, Justice was getting a new diagnosis every 2 years, and I would find myself going right back into one of those stages of grief. But I was able to recognize those emotions, those actions, and work through that behavior to that acceptance and upward turn phase. So I've just found it helpful to reframe it like that.
Yeah.
I think that grief and mourning is totally fine. And maybe some people aren't experiencing it, but I do think that there are so many things that you think and expect when you become a parent. And when you recognize that some of those things are not going to be the way you thought, that is a grief and a mourning process. And it gets you through to the point, oh my goodness, this beautiful child that I'm a parent of and I love so much. And this is exactly the relationship that I always wanted. I just had to take the time to get through all of that.
I think sometimes it's, for some parents, less about their thoughts and feelings about their child's differences. And it's more about the fear about what their child's life is going to be like,
Oh, yeah.
right? Which is a kind of a different spin on the grief and mourning. This plan has been in your mind, and all of a sudden you're at a fork in the road, and the plan might need to change. And that level of change is hard for very many of us.
The one thing that I didn't appreciate about having my kids diagnosed, and that they weren't super young, but it allowed my kids to grow up knowing they were autistic in as much as they could. It was a conversation that we had all the time in our house. It was not a word that evoked shame or whispers or side conversations. It was just part of the daily vernacular in our household. And so by the time my youngest, Noe, was in third grade, they were already advocating for themselves. They already knew what stims were, what that did for them, how they used their imagination, what some of that sensory stuff was. Now, by the time they were in middle school, it changed a little bit how they wanted to identify. They were more than happy to identify with ADHD because, so much more common. But then neurodivergent TikTok came around, and now it was all the rage. And Noe saw themselves everywhere with those content creators. I haven't heard anyone say, I'm so glad I didn't know sooner. Not a single person. Everyone who was diagnosed late as an adult with autism is going back and reviewing all of those years that they didn't have the diagnosis, wondering how their life could have been easier, how they could have understood themselves better, how peers might have understood them better, how they might have gotten better supports, more understanding from their parents, or fill in the blank. I'm not saying everyone should rush out and go ahead and get their medical diagnosis because it's going to change everything, but don't underestimate the value of the community that can provide in having that diagnosis.
I absolutely second that. And I will also say, like, when people are going through the diagnostic process, one of the most common questions that we get for a 1, 2, 3-year-old is, okay, so is there a chance that they're going to grow out of it? Is there a chance that they're going to lose the diagnosis? And we go through the research and the stats on that and what that's going to look like. And then I now end with saying, but you might not want them to, and they might not want them to, because this is a part of them, and it's okay. Again, to have individuals being able to communicate about it is so helpful to other people. So I think usually the medical diagnosis is helpful. I know it's hard to get. I know that we still need to work a lot on being able to get enough availability for diagnosticians, especially if you're an older adolescent or an adult. It just does give you so much understanding of yourself and a whole community of people who you feel like, wow, I'm not the only person. I'm actually one of many. That's helpful.
Is there anything you want to say as we close out?
I want to thank you for the opportunity to have this conversation. What an honor it is to have been a part of your family for 23 years, I think. And it is just such an example of why I committed to the community and committed to our families and recruiting more wonderful people to be able to do this, because to be able to watch your kids grow up, other kids in the community, and to see them being successful young adults, and to know that I was a part of that is just the greatest thing. So thank you for inviting me.
Autism is one of my favorite things to talk about. Autism kind of landed in my lap. I fully admit this was not the path that I necessarily set out to. I knew I wanted to be a pediatric neuropsychologist, but I did not know that autism was going to be such a big part of my path. And I remember when I started my graduate training, my advisor, Debbie Fine, at the time was like, it's okay if you don't know about autism. I can teach you everything about autism that I know, but I can't teach you how to think. And it's been the best ride. I'm really glad to still be able to do some early autism evaluations. They are my favorite type of evaluations to do. I love working with families and children through that initial process and getting to see how they evolve over time. So getting to talk about this is always fun.
Thanks for joining us for this episode of Chelsea's Vocation. We hope it was valuable to you. If it was, we'd appreciate you sharing it with someone, reviewing it, and/or rating it. Subscribe to the podcast to be notified when new episodes are published. We wish you the best as you learn, maybe unlearn, and do better for yourself and those around you. Chelsea encourages you to be gentle with yourself, be gracious with others, and be protective of your own and others' dignity. Until next time, take care.